Hello, my name is Dr. Roger Blumenthal, and I'm editor-in-chief of the new dyslipidemia clinical community, which is now available on CardioSource. It's a great pleasure for me to talk to my longtime friend and colleague, Dr. Christie Ballantyne, who's professor of medicine and chief of cardiovascular research at Baylor College of Medicine. Christie is one of the leading authorities on atherosclerotic vascular disease, and he recently chaired the ACC LDL Summit that was held on October 10th, 2013 here at Hart House. And we were interested in getting Christie's views about targets and some of his thoughts that pertain to the guidelines. So first off, welcome, Christie.
Thanks, Roger.
Christie, I note that topic one, when you had the LDL think tank, was dealing with guidelines. What is their treatment target? How were they developed? And what will their role be in the future? As you're aware, there is not an emphasis on targets in the new guidelines. And I was wondering what your thoughts were and how you think you will practice going forward. And maybe tell us a little bit about your thoughts on the evidence supporting non-HDL as something that some clinicians may want to pay attention to.
So, Roger, it's interesting to look at guidelines, and particularly these are where we take this NHLBI process, and then there was an AHA-ACC guidelines issued. But if we go back to the initial process, they were really looking at just three questions. What is the evidence for an LDL cholesterol target for secondary prevention? What is the evidence for primary prevention? And discussion about the efficacy and safety of the drugs. So, and then they only used studies which had an extremely high level of evidence, basically hard outcomes, RCTs, so you could come up with a 1A recommendation. And I think if anybody were on the guidelines, and I forget, Roger, were you on the guideline committee or not? But if I'd been on the committee, I would have come up with the same answers. If you were given those studies to review, and you say, well, is there, really strong evidence that there's a specific LDL cholesterol level for secondary prevention? No, not really, and nor is there for primary prevention. But remember, the answer to the questions depends upon the questions asked. And if we had asked some different questions, what is the evidence for atherogenic lipoproteins causing atherothrombotic disease? Well, the evidence would have been overwhelming. Yes, they are directly causally related to the disease. What is the evidence that if you have a high level of LDL, you have a high lifetime risk for heart disease? Once again, would have been a resounding yes. And what is the evidence that lowering LDL, and we'll talk more about what you measure, but really atherogenic lipoproteins are more than just LDL cholesterol. What is the evidence that lowering LDL has benefit by more than one modality, not just statins, but other means? The answer would have also been yes. And finally, if you said, if you get lower with therapy, do you have better outcomes? That answer would be yes, if those had been the four questions. So, I think we have to look carefully that there's not a strong evidence for a target. Doesn't mean that there's not strong evidence that high levels of LDL cholesterol and non-HDL cholesterol are bad and low levels are good. Do you follow me, Roger?
Exactly. So, Christie, let me take that a step further. Let's take the ACCORD study where we had everyone getting 20 or 40 milligrams of simvastatin. Half of the people get fenofibrate. The median the median triglycerides was around 165. But in those individuals with triglycerides greater than 200 and a low HDL, there was nearly a statistically significant decrease in events. So it seems like the committees decided to say there's not evidence that adding a second agent is beneficial. But if you look at the totality of evidence, I would submit that when you have triglycerides greater than 200 and a low HDL, we have strong suggestive data that maybe looking at non-HDL is important to try to target, because adding a second agent looked like there was a strong trend for benefit. So I was wondering if you might comment on your interpretation of ACCORD.
Well, I would actually say, why don't we even look at the ACCORD blood pressure? In the ACCORD blood pressure, you took people who were treated well and their blood pressures were below the 140/90, our usual goal, and you had people who were treated a little more aggressively, and there was no overall reduction, although there was some reduction in stroke. So if you had just looked at that alone, you would have said, well, it doesn't really help to treat blood pressure more aggressively at all. But we wouldn't have said that would apply if your blood pressure were 160/90 versus 140/80. In other words, if just that study alone, people say, well, there's not the rationale for maybe lower targets, but they don't say that there's no benefit for adding a second drug. Now, the reason I bring this up is the two trials, if you looked at, for example, the Accord lipid, there's no difference in LDL cholesterol by adding fenofibrate. You do have some benefit for non-HDL and high triglyceride, and there may be a subpopulation with benefit, but basically you took people on a pretty good dose of statin with pretty good LDLs. If you look at AIM high and HPS2 Thrive, the LDL was 65 versus 68 in AIM high and HPS2 Thrive. The baseline LDL was 65. So the same concept would be as if we took people who were on antihypertensive therapy and their blood pressures are 125/80, and you add a second drug and there's no benefit, we would imply that lowering blood pressure and adding two drugs doesn't give benefit. Well, it certainly might if you had a high blood pressure, because we know that from the old studies, not from the new studies, from the old studies. And what was done for the lipid trials, it was felt that it was unethical to take people who were poorly controlled, had extremely high LDLs, and then randomize them in a trial. So we don't have the outcomes that lowering LDL in poorly controlled patients gives further risk reduction, because they weren't included in those trials. They weren't included also in the ezetimibe trial, the IMPROVE-IT study. The question has never been studied. If you have a patient on a statin and their LDL, if someone with heart disease, their LDL is 130, 140 LDL, and they're on a high dose of a statin, just adding a second drug help that patient, no one has ever done an RCT focused on that. So we have a lack of randomized trials, and I bring up this whole blood pressure issue because in the past we had some studies where if you had, very poor control with one agent, you had a second agent, you got some better reduction. We never did that in the modern statin era with it. So does a lack of evidence mean that there's a lack of efficacy? Well, it means there's not enough evidence for a 1A recommendation to go into the thing. But there was a nice article in one of the British journals that talked about basically they were doing an evidence-based review in terms of reduction of gravitational injuries by parachutes. And they did a meta-analysis of all the RCTs, and they said, well, there's really no evidence for any benefit of parachutes because there's no RCTs. So therefore, we can't really state that it's wise to use a parachute to try to reduce gravitational injuries. And we all laugh at that and say, well, that's silly. But, I would say the same thing is to say that you don't have strong evidence for a target doesn't mean that high LDLs are bad and that lowering LDL is good. It means that we don't have evidence for a specific number. So kind of a long answer, but do I think looking at LDL cholesterol is still important? Absolutely. And in fact, our work and yours and many other, Roger, that non-HDL cholesterol is actually a better measure of your atherogenic cholesterol than LDL cholesterol. And so if you have a high level of non-HDL cholesterol, you should be concerned. Do we know exactly what to do with that patient? No. But is there some evidence that they may benefit from therapy? Yes, there is.
So, Christie, in the last couple minutes, I wanted to just focus in on primary prevention with you. And the new guidelines talk about if you have a atherosclerotic vascular disease risk of greater than 7.5%, that you should go on statin therapy even if you have normal lipid levels, even if your LDLs are between 70 to 100. And you've published a lot of data about emerging risk factors, and you've done work with things like coronary calcium. And what we've learned is that the Framingham score and the derivations of it are dominated by chronologic age. And I think one of the areas of pushback will be in individuals who are fairly close to the 7.5% threshold, mainly because of their age, but have normal lipid levels. The new guidelines strongly recommend treatment. Just curious what your thoughts are in the last couple minutes.
Well, I'm not exactly sure why 7.5%. I would say if someone is, and this is once again a little bit, if someone is 5% and you have a clearly elevated LDL, then I think that's something that we know that there's an increased lifetime risk, particularly for a younger person, and that we can reduce that risk based upon extrapolation of our trial data. It's not quite so clear, on the other hand, that if I have an older patient who's 7.5%, that I'll get that much benefit with a statin if they have a low LDL, because once again, they wouldn't have gone in a lot of the studies. Now, if they have a high CRP, other criteria, yes. So, you know, I think the issue is the guidelines are always, we point out that we need more evidence, we need more trials to look at important questions, such as some of the ones we've talked about today. What about if you still have high LDL on a statin? What about if you can't take a statin? And I think we really haven't done, Roger, enough work in regards to how would we actually use biomarkers and imaging to guide who gets preventive therapies. And I think that's prevention of CHD with statins. I think prevention of heart failure is going to be a great area for future research. But we are always, when he set of guidelines, remember there's going to be a new set in a year and a half to 2 years as we get more data.
Well, Christie, that was a tremendous summary. We really appreciate your insights and wanted to thank the audience for their attention today. And I hope that members of the ACC will visit the dyslipidemia community frequently. And we look forward to interviewing Dr. Ballantyne, clearly one of the leaders in this field, on a regular basis. This is Dr. Roger Blumenthal for the CardioSource clinical community on dyslipidemia. Thanks so much, Christie.
Thanks, Roger.